All right, well, good evening, and welcome to this TSRA Journal Club entitled 4 Practice-Changing Papers in Cardiovascular Medicine. It's our pleasure to join you tonight for what will be a really lively and engaging and indeed timely discussion. First, I'd like to extend our thanks to Atricure for their educational grant, which has made tonight possible. And then secondly, I'd like to launch right in by introducing the co-moderators. Myself, my name is Ray Strobel. I'm a PGY4 cardiothoracic surgery resident at the University of Virginia. Dr. Kerkar.
And my name is Ashwini Kerkar. I'm a second-year general cardiology fellow at the University of Michigan. I plan to pursue interventional cardiology, so this will be a relevant discussion for everyone. I have the pleasure of introducing 2 of our interventional cardiology panelists, Dr. Molly Szerlip, who will be joining us a little late, and then Dr. David Cohen. Dr. Szerlip is the medical director of the percutaneous valve program at Baylor Scott & White Heart Hospital in Plano, Texas. She oversees both the TAVR program as well as the percutaneous mitral and tricuspid programs. She's also the program director for the cardiology fellowship program at Baylor Scott & White. She's currently chairman of the SCAI Publication Committee and is a member of the SCAI Board of Trustees. Her expertise has made her a rising figurehead in major studies related to percutaneous valve treatments. We'll be happy to have her join us soon.
I'm here.
Oh, great. Dr. David Cohen is currently the Director of Clinical Outcomes Research at the Cardiovascular Research Foundation. He's the Director of Academic Affairs at St. Francis Hospital and then faculty member at Columbia University. He's an interventional and structural cardiologist with more than 25 years of experience in the field. He's also a prolific researcher who has published over 550 articles in leading journals, including the New England Journal of Medicine and The Lancet, and serves on the editorial board of the American Heart Journal, JACC Interventions, and Circulation. Excited to have you with us, Dr. Cohen.
Thanks so much for the introduction. Great to be here.
And I, of course, have the pleasure of introducing our 2 surgeon panelists. First, Dr. Gorav Ailawadi, who is professor and chair of cardiac surgery at the University of Michigan. He is an internationally recognized surgeon with expertise in minimally invasive mitral valve surgery and transcatheter valve therapies, with notable accomplishments including being the first United States surgeon to perform the MitraClip procedure and having performed over 800 minimally invasive cardiac surgical procedures. His lab's research has resulted in over 425 peer-reviewed manuscripts and has been featured in NEJM, Circulation, and JACC. Welcome, Dr. Ailawadi.
Thank you, Ray.
Thank you. And Dr. Faisal Bakaeen is professor of surgery and distinguished chair in thoracic and cardiovascular surgery at the Cleveland Clinic. He is a world-renowned surgeon with expertise in coronary revascularization and minimally invasive surgical techniques. He has published extensively in the field of cardiovascular medicine, authoring over 280 papers. And he is a thought leader within cardiac surgery regarding the continued debate over the ACC/AHA SCAI coronary artery revascularization guidelines. Welcome, Dr. Bakaeen.
Thank you, Ray, and thank you, the TSRA, for this wonderful honor. Good to be with you tonight.
Absolutely. And so without further ado, we'll move on to our first topic for the evening, which Dr. Gorav Ailawadi will present.
Great, Ray, and Ashwini, thank you again for the invitation. Thank you, the TSRA. I was asked to talk about CoOp versus Mitra FR, and I think these are both important papers that I think all cardiac surgery trainees should be aware of. Here are my conflicts. I do have consulting relationships with companies that make these transcatheter devices, although none of them are significant, unfortunately or fortunately. But so in terms of the patient population, really going to focus on secondary MR. I think everybody on this call should be well aware of what that is, where it's really a disease of the ventricle and not of the mitral valve itself. And this has been a challenging patient population for all of us, including cardiac surgeons, although these populations we don't often see as much. And there are 2 important publications, both the CoOp trial on the left and the Mitra FR trial on the right. I want to highlight a couple of components of those trials, which have then led to some very disparate conclusions from the 2 trials. So the CoOp trial, the main conclusion was that there was a lower rate of heart failure hospitalization and mortality at 24 months. That was the primary endpoint. whereas in the Mitra FR, and this is a French study, the rate of death and heart failure hospitalization at 1 year did not differ. And the editorial comments really stated that there was a possible role for the device. So clearly a committal conclusion there. I do want to highlight, this is a nice graph from CoOp showing the 1, 2, and 3 year results. And what I want to highlight is these curves appear to be growing further apart. And what you see, MitraClip plus guideline-directed medical therapy, the curve in green is the lower curve. You can see that the cumulative rate of heart failure hospitalizations are significantly less than with GDMT alone. And this again continues out to 3 years, and that's important because a couple hot things I want to highlight over the next 3 slides are the main differences between Mitra FR and CoOp. Here show Mitra FR on the left. The study size was about half. The follow-up was 1 year instead of 2 years in terms of the primary endpoint. In terms of the GDMT criteria and bar to get into the trial, they were quite a bit different. With the CoOp trial, there really was a very rigorous heart failure team that would analyze every patient and determine if the medical therapy was really truly optimized, and often push back on the team that was treating the patient to optimize it as best possible. Whereas the Mitra FR, there was a little less overall scrutiny, and there was a little more real world approach, whereas the treating site could alter and vary this. It wasn't as standardized. And again, in terms of outcomes at 1 year, they were different. If you look at the very bottom line, 12-month outcomes of MitraClip with 3+ MR or worse, so what we'd really consider not an ideal result, 17% in the Mitra FR group versus only 5% in CoOp. The other thing to highlight is these patients were a bit different in terms of the degree of mitral regurgitation, as well as their end diastolic volumes. And I'd like to highlight just these 2 rows. The CoOp group on the left, you can see the Eroa, which is how we define severe MR, or degree of MR, was substantially higher in CoOp, whereas the end diastolic volume was substantially less with CoOp compared to Mitra FR. So this is something we're going to talk about in a second. And then overall, in terms of the safety and efficacy, you could see procedural complications was only 8%, 8.5% in CoOp, and was almost 15% in Mitra FR. And I think that was a testament to probably the larger experience that the treating sites had in the United States. So I want to emphasize this concept of Eroa and end diastolic volumes. And there's a concept that one of Molly's partners, Paul Graber, has been putting forth, and I think a lot of us are starting to understand and look at our own data and seem to be falling in line of what we consider proportionate versus disproportionate MR. And I'd like to, let me go back there. So I want to share 2 different scenarios, 2 different patients. So both patients have what we would define as severe mitral regurgitation. Patient 1 has an end diastolic volume of 150 compared to patient 2. Has double that, about 300. The ejection fractions are about the same. Total stroke volume and forward stroke volume are very different. And what you see, the forward stroke volume in patient 1 is much less because the regurgitant volume is a larger proportion of the stroke volume. So the proportionality of MR relative to the end diastolic volume is much greater in patient 1, and hence a higher regurgitant fraction. And then when we look at, here's a kind of the spectrum of secondary MR, it's sort of a big catch-all, but the reality is they are quite different in terms of the patient populations. Can be anywhere from the left, a very dilated ventricle, a low ejection fraction. The GLS, which is the global longitudinal strain, is very low, to the patient on the right, which has a more preserved ventricle, smaller end diastolic volumes, but yet still has severe MR. Okay. And when we graph this out on a graph such as this, again, comparing the EROA by the left ventricular end diastolic volume, and you can imagine here patients that are on the upper reddish component, those patients have a lot more EROA or a lot more MR compared to their diastolic volume. Patients that are on the green component have a lot less EROA or a lot less MR compared to their end diastolic volume. And when we look at the two populations that were studied, the CoOp population fell well in the center of the disproportionate severe MR, so proportionality or severe MR out of proportion to their degree of LV dilation and LV function. Whereas the Mitra FR component group really was bordering on patients that had what we consider, or what was now defined as proportional MR. Another interesting component was just looking at the graph on the left and on the right. These are a sub-analysis of CoOp patients, those that had a less MR and dilated ventricle on the left, and you can see that there was no difference between the two curves, so no difference between MitraClip versus GDMT, whereas on the right, it was severe MR, EROA greater than 0.3, and a smaller left ventricular end diastolic dimension, so less than 96 mLs per meter squared. And you can see that those curves are different. Patients that had a MitraClip had a much better result. So giving us some signal as to which patients may be best served with TEER approaches. So which patients with FMR benefit? Really, I think it comes down to a few things. One is patients with severe functional MR after optimal GDMT, and ideally, potentially those patients that don't have a dilated ventricle. Number two, patients who have a good result with MR reduction following MitraClip. And this is where I think the experience and the heart team working together, including the imagers, is very essential. And then finally, really trying to avoid patients that have really dilated ventricles. You'll get the most optimal outcomes in patients with disproportionate severe MR relative to size. I think with that, I will end, and I think that's time for some questions. Happy to take any questions.
Thanks, Dr. Ailawadi. You know, with such hugely positive results in CoOpt, I think your slide sort of talked about a number needed to treat about 3 patients. Do you think that we have a good system in place for getting patients this procedure?
It's really interesting because you know, you see wide variation in how heart teams are approaching these patients. So teams that I think that have been involved with this patient population for a while, maybe those that have been involved in clinical trials, have a functioning heart team, including the heart failure specialists and the imagers. And I know we have a lot of scrutiny in our weekly calls about which patients will benefit versus which are probably not going to benefit. I'm not sure that that degree of robustness exists at all programs, particularly those that are maybe newer to using transcatheter repair devices, where there probably isn't quite the same scrutiny. I do think in the end, it's going to be important to get the results that we saw in CoOpt.
Yeah, I think it is very center specific, I think, as Gorav said. And, you know, one of the things that went by a little bit quickly in his presentation is the importance of getting the patients on appropriate medical therapy before they're, you know, these FMR patients, before they're considered for MitraClip or any form of TEER therapy. That was, you know, this really critical piece in CoOpt, and one of the major differences with Mitra FR. And I'm sure Molly has some thoughts about that as well, I can imagine.
Mm-hmm. Yeah, so actually, as I said earlier, Paul is actually one of my partners and is an active member in our mitral clinic. And it is very important to get on GDMT, but I guess the biggest controversy or the biggest discussion that people are having now is how much GDMT to put people on. So I think you know, Milton Packer talks about this a lot, that it's not necessarily that everyone has to be on max amounts of all GDMT before you get the benefit from MitraClip, and it may just be that they need to be on all the GDMT and then maybe mitral clip should be, or actually I should say TEER therapy should be initiated. So I agree that, and I think we've all seen it, that patients with really, really large LVs and just don't do well with TEER therapy. And that's more a function of the problem being the LV as opposed to anything else. And you're right, it is very clinic specific. I think people who have been doing it a long time or even part of the CoOp trial really tend to, be able to weed those out, whereas maybe some of the newer programs that are starting have a little bit more hard time doing that. But yeah, I mean, I think that's with all clinics.
Yeah, Molly, I just want to add one other component is, we see a lot of these patients that have both a significant MR and significant TR, and in CoOp, those patients were excluded. I suspect nowadays those patients are being treated because we can, and maybe it'll help them somewhat symptomatically. Although when we look at the TVT data, we know that patients with severe MR do much worse, have a much higher long-term mortality. And so that's still a patient population that we struggle with, and that wasn't really studied in CoOp, or Mitra FR for that matter. Yet I think we're treating those patients not infrequently.
So I want to ask a question, if I may. It's not my area of expertise, but I do enough ischemic MRs as part of CABG, and I think this is slightly a different animal because most of those patients probably didn't have a revascularization option or good revascularization option. But for those trainees who are outside the US, and are they convinced that the CoOp can be explained because of patient selection in terms of ventricular and diastolic volume and proportionate versus disproportionate MR, or still there's a dissociation between North America and Europe?
Well, I don't know how outside US explains it, but I think Paul and Packer have done a good job with validating their theory. I think they've published another paper where they validated their theory, and it actually goes along pretty well, to explain the theory.
But I think it is, I mean, it's definitely an area that, is unresolved, and unfortunately it may remain so for a long time. There was supposed to be an effort. I mean, I worked with the team that was trying to get the individual patient data from the two studies to be able to combine them together in order to help tease that out, because then we could actually, and part of that was going to involve rereading the echoes from France, because it turns out that the definition of severe mitral regurgitation in Europe is a lower EROA than it is in the United States. They used a cutoff of 0.2, and we use 0.3. And so it's, we wanted to do all that stuff. And my understanding is whatever the deal was, it took so long to put it together that everybody ran out of time and patience. So it may never happen, unfortunately. But it really would have been good to see that.
Thank you.
Yeah, David, I certainly, based on the data that I presented, there is a signal that there are some differences in the severity. So it would have been very nice. But we also have a large multi-center registry called the Empire Registry that one of my colleagues has put together, and he's analyzing it right now, looking at proportionality, and it looks like there's also going to be a signal in 600 plus patients. This is but no control group, just TEER, yeah. Correct. So that's the tricky part is, again, these two trials, we would have had 900 patients randomized. I mean, it's a shame, but we move on. Last question for me, for Molly and Gorav. Do you think we can beat this in FMR with transcatheter mitral valves? We know we can make the MR go better. Molly, you want to start? I can.
You mean as opposed to?
So we take these same patients. So we take the CoOp group, and we have good, and we treat them with with mitral valve, transcatheter mitral valve replacement with whatever device ends up getting approved. We screen out the ones who are going to have LVOT problems, and off we go. Would we do better or would we do worse?
Yeah, I'm not sure I can even predict that one. You
Take a
know,
guess.
the problem with tier long-term is, I mean, we're seeing, well, actually, we don't really know long-term what's going to happen with tier, though. I think all of us who have some of the original CoOp patients may be seeing some of those patients come back, not with stenosis or anything, but recurrent MR or worsening MR, you know. And the problem with the transcatheter mitral valve replacement is obviously the long-term anticoagulation. So, yeah, I think that's going to be one of those head-to-head studies that eventually we'll see if and when a transcatheter mitral valve replacement option becomes commercially available. Right now, it's the best thing that we have for this patient population that otherwise probably would not be treated.
Yep, I think that's a great summary. It's hard right now to compete it with the safety profile.
Yeah,
of
that's
tier.
Yeah, I think that always ends up being the Trump, the Trump factor is it is an incredibly safe procedure for a pretty sick group of patients.
Thank you all for your discussion. I think we'll move on. So it's the 20-year anniversary of TAVR this year. And so I think we can move on to talking about protected TAVR with Dr. Cohen.
Well, thanks. So something no less controversial here, the issue of cerebral embolic protection at the time of transcatheter aortic valve replacement. So stroke is, a problem with any form of aortic valve replacement. It's been there since TAVR was introduced. It makes sense when we know that when we do TAVR and we dilate the valve, when we cross the native aortic valve, even crossing the aortic arch, emboli are liberated, no question. And the stroke rates have been really, if you look at mortality, it's come down quite a bit. If you look at things like paravalvular regurgitation, length of stay, they've all come down, and the stroke rates have been almost flat, maybe finally starting to budge down in the last couple of years with the introduction of the low risk patients, but pretty solid stroke rates. It's not a negligible event. And so with that in mind, and trying to fix that problem, a number of different embolic protection devices to protect the cerebral circulation have been developed, and one is available in the United States. This is the one that's available in the United States, the Sentinel device, which is a dual filter. It's inserted through the right radial artery in a 6 French sheath. The first filter is deployed in the innominate, and the second filter is then manipulated up into the left infernal carotid, or common carotid, excuse me. You can, those of you who know your neuroanatomy and head and neck vessels know that there's a missing vessel here that is not protected, which is the left vertebral. And we can talk about that. And this device was tested in a trial called the Sentinel IDE trial, which was about 360 patients randomized to device or no device, with a primary endpoint of the volume of new lesions on a cerebral MRI at 2 to 7 days. And you can see the results there, and you can see the p-value was non-significant. And so one would think, well, the device didn't work. It didn't meet its primary endpoint. So, I'm sure it wouldn't get approved, but nonetheless, it was absolutely approved by the FDA. And the label is this. So it was not approved for prevention of stroke. It was not approved for reduction of brain infarct lesions. It was approved to as an embolic protection device to capture and remove thrombus and debris. So basically, it was approved to catch stuff before it got to the brain. And that's nice for the company that makes the device, but leaves all of us who do this procedure in a bit of a quandary as to whether it actually works or not. And so with that in mind, and because quite frankly, the use in the United States did not take off the way that the company that sells this device thought it should. They launched several trials. The one that I'm going to be talking about is the protected TAVR trial, which is the first trial that was designed to see if it could reduce stroke in patients undergoing TAVR. So it's a big trial, 3,000 patients undergoing transfemoral TAVR across the risk spectrum, randomized 1-to-1 to standard TAVR without any cerebral protection, or TAVR with the Sentinel device. Importantly, all the patients were seen by a neurology professional before the procedure and afterwards. So they had standardized neurologic assessments. And the primary endpoint was all stroke at 72 hours or hospital discharge, whichever came first. So if the patient went home on day 1, it was a day 1 neuro exam. If they went home on day 3, it was a day 3 exam. If they went home on day 7, it was a day 3 exam. And importantly, the study was powered to detect a 50% reduction in stroke from 4% to 2%, and we'll come back and talk about that towards the end. Here's the flow of the patients. It was very well done randomized trial. The vast majority of the patients, very small loss to follow-up rate. You can see that about 5% of the patients on the right-hand side who were assigned to get embolic protection did not get it, usually because of technical issues, spasm, or unfavorable anatomy in the arch or the innominate distribution. But the vast majority did receive the device. These are the patient characteristics. Very typical. This trial was enrolled during COVID, so 2000, 2001. So really a kind of all across the risk spectrum, 79-year-old, about 40% women, risk score of about 3.4. And you can see here that a third, high, medium, and low risk. Just looking at some of the procedural characteristics in terms of the anatomy, valve anatomy on the right-hand side, tricuspid valves were about 90%, bicuspid valves about 8 to 9%, and about 3% were valve-in-valve, treating a TAVR to treat a failing surgical bioprosthesis. 2/3 of the valves were balloon expandable, and 1/3 were self-expanding. And here's the primary endpoint. There was 2.3% of the patients in the Sentinel group had a stroke within 72 hours, and 2.9% in the control group had a stroke. You can see this was a 0.6% absolute difference. It was not close to statistically significant. However, when the investigators looked a little more closely at the results and looked at a number of their secondary endpoints, one of the secondary endpoints, one of 6, was disabling stroke. And when they looked at disabling stroke, which was defined, as really a major stroke that had a several point reduction in the modified Rankin scale. Here, the difference was actually a similar absolute difference, about 0.8% absolute, but now it met statistical significance with a p-value of 0.02, and everybody was pretty excited about this finding. In terms of other results, you can see here none of the other secondary endpoints that were tested, including mortality, delirium, a composite of stroke TA or delirium, none of those were reduced. The device was very safe. There was only 0.1% vascular complications at the access site for the Sentinel device through the right radial artery. In terms of subgroups, so let's see, maybe there's groups that would benefit more or less. And so these are kind of all the subgroups that were looked at. And just a couple that I want to highlight here. If you look at the valve morphology, a lot of people think bicuspid valves are worse. These differences were not at all statistically significant. There was no significant interaction here. Aortic valve calcification, actually, there was less benefit, if anything, in the moderate or greater calcifications. No difference in the outcome, whether the patient had a prior stroke or not. No difference whether it was valve-in-valve or not. Again, very, very low rates of events in the valve-in-valves. And the valve type didn't matter as well. So it didn't seem like subgroup analyses helped us very much. That's the same slide, sorry, I duplicated. So the interesting thing about this study is you've seen the results, negative for the primary endpoint, and then this interesting finding of possible benefit on the secondary endpoint of disabling stroke. And so in the New England Journal of Medicine paper that they published, this is the conclusion in the abstract. Among patients with aortic stenosis undergoing transfemoral TAVR, use of cerebral embolic protection did not have a significant effect on the incidence of periprocedural stroke. But on the basis of the 95% confidence interval around this outcome, the results may not rule out a benefit of embolic protection during TAVR. It's really kind of a mouthful. They really struggled to get a conclusion that the journal editors plus the authors were happy with in some sense. What they really wanted to say is what they said when they presented it at TCT. This is what Samir Kapadia, the principal investigator, said. He said, cerebral embolic protection in TAVR prevents disabling strokes. And cerebral embolic protection with the Sentinel device should be considered for all patients undergoing TAVR for reducing disabling strokes. So these are pretty distinctly different conclusions. And I really want to focus on sort of why they differ and at least my own interpretation of the data at this point. So my own personal interpretation of the benefits of Sentinel and TAVR are that it captures debris. We've had 3 randomized trials. I didn't tell you about them. There were 2 other very small ones. And every single one of them, it captures debris. And 99% of patients, you put this device in, you can get something out. It might reduce CNS lesion volume in protected territories. Of the 3 trials that looked at this endpoint, 1 of the 3 was positive, 2 of the 3 were negative, including the one that was taken to the FDA. And as far as I'm concerned, the unproven benefits are a reduction in stroke. At this point, we have 0 out of 3 trials that show a reduction in stroke. There was a meta-analysis, which is just on the border of benefit. There are several large observational studies, including one that I presented that I'll show you in a minute, that showed no benefit whatsoever, except for one that did the analysis completely wrong. And we don't have any evidence right now of improved neurocognitive outcomes late, which is, again, a theoretical benefit. So, you know, if you're sort of a purist and you look at the data that way, I think that's what those are the conclusions you would draw. So why didn't it work? And I think this is really the, you know, interesting question. We know it catches stuff. So why didn't it work? And the answer to me actually is, you know, it is, you know, probably a bunch of different things, but in the trial, it didn't work because they underpowered the trial. And what do I mean by that? So this is data that we published. This is from 110,000 patients treated in the TVT registry, where we did 2 different observational analyses comparing embolic protection to not. Something called an instrumental variable analysis, which is a very specific technique that is sort of a quasi-randomized design, which showed a relative risk of 0.9 with confidence intervals that covered 1. That we also did a propensity weighted analysis, another form of observational analysis that's a little more subject to confounding, which showed a borderline significant risk reduction with a relative risk of 0.82. And so on the basis of these findings, the protected TAVR investigators initiated a study where they looked for a relative risk reduction of 0.5. And, you know, if you're going to ignore this kind of observational data, and they did ignore it, because I actually, when they started the trial, I spoke to Samir Kapadia, the primary investigator. I said, what are you powered for? And he said a 50% reduction. I said, you're crazy. It's never going to be that big. And here's the results. This is the study results on that same scale. I mean, I think the study results are very consistent with what we saw in the observational data. They were just incredibly optimistic about the strength of the effect. And then finally, I just want to, you know, touch on, well, what about the disabling stroke data? I mean, that's really is what they're hanging their hat on. And there's absolutely no question that disabling stroke is the endpoint that our patients and their families are most concerned about with TAVR. That, you know, 0 question in my mind about that. And I think that, you know, in light of previous studies and what we understand about these mechanisms, the suggestion that embolic protection converts major strokes into minor strokes, which is what the data would seem to suggest, is certainly mechanistically and biologically plausible. Maybe we don't catch every piece of debris, but we catch the big pieces, and that, you know, and that could have this effect. But, you know, what I have to say is that in the context of an overall neutral trial, when this was a secondary outcome among 6 other ones that were assessed, all of which were neutral also, really doesn't for me pass the boundary of, you know, I can absolutely accept this as being true. If you look at the confidence intervals just based on this analysis, the absolute risk reduction for disabling stroke could be as low as 1 per 1,000, even before taking into effect that we have multiple comparisons. And in fact, if you look at the paper, in the paper, Samir Kapadia himself writes that the 95% confidence intervals for the secondary endpoints should not be used to infer definitive treatment effects, meaning you have to take it with a grain of salt. Final point I want to just, you know, make is, so why not? So, okay, we're not sure about the disabling stroke data, but we're sure it's safe. So why shouldn't we use this in everybody? And the answer to that is, you know, I mean, shouldn't we do everything we can to prevent stroke? And it really comes down to cost. It's that simple. In the United States, we do about 90,000 TAVRs a year in the United States, and the device costs $3,000, and that's $270 million a year if you did it in everybody. If you're a typical high volume US hospital, which is, I think, smaller than all of the hospitals of the panelists here, that does 200 TAVRs per year, that's $600,000. My hospital, we do 600 TAVRs a year. That's $1.8 million a year of TAVRs. Faisal's hospital does 750. It's, you know, over $2 million a year they spend on embolic protection devices, and there's no extra payment for it. There was for a little while. What could you do? So the real question really comes down to, at the hospital level or the healthcare system level, what could you do with an extra $600,000 a year? A lot. You could have 2 to 3 new APPs, you know, on your service. Everybody would love to have a bunch of extra APPs to help them with the work. You know, if you're like me, you could have a new cath lab every 3 years. We could buy a new cath lab for the hospital. At the Cleveland Clinic, they could buy one every year. I don't know how many, you know, TAVRs all of you guys do, but you can do the math. So there's a lot of things that you can do for something, you know, rather than something that we don't know even works. And I just leave you with that thought. Again, it's a very challenging area. And there's a lot of variability that's out there, but I think it's something, you know, again, interesting to think about. But you know, the real message here is I think we need confirmatory studies, because this secondary endpoint in a negative trial is just kind of a lonely endpoint.
So David, I'm going to pretend that Samir Kapadia is here, although he always acknowledges that you told him it was going to be a negative trial, and you were right. But I wish that Samir, and he might still do it.
I've done this with Samir many times. So you play Samir.
I'll call him on my cell phone. But I guess I wish they would do, maybe they're planning, I should ask him, the economics, because disabling strokes are very, very expensive. That is something that you didn't factor in your last slide. Mm-hmm. Perhaps you will be net negative, or maybe save money by cutting down on disabling strokes. Now, I'll let you respond to this, but I want to finish by engaging Gorav. Gorav, you remember many years ago when Mike Mack, through the Cardiothoracic Surgical Trials Network, they launched a study using a device to catch emboli during open heart surgery. And they stopped the study prematurely because they found no difference in outcomes. But I always thought they're totally different, because with the Sentinel device, you go with a CT scan that was done preoperatively, and you know exactly where you're going with your wires, you know exactly where you're deploying the catchment device. But when we did the surgical device, we blindly deployed it into the arch, not knowing what's protected, what's not, and whether there was any snow plowing effect and actually inducing stroke by deploying that device. So I'm interested to hearing your feedback, both David as a rebuttal and Gorav.
Yeah,
go first.
Great point. I guess I'll only add, David, you know, I guess your final comment is we need more studies. I guess, do we really need more studies? I mean, what you're showing is there may be an effect, but it is very small.
We need a
very small beneficial effect. And one thing I would love, if you have at your fingertips, what's the number needed to treat in order to prevent a stroke? I'm sure it's
well. I mean, it's, you know, one. I mean, so the number needed to treat to prevent a stroke is infinite, because we don't even know if we're preventing strokes. If you take the numbers at face value of a 0.8% absolute reduction in disabling stroke, you know, and you use that number, it's about 120 to prevent a disabling stroke.
Right.
And you know, I mean, I personally, if I was confident that that was the number, I'd say it's worth it. It probably is. I mean, but my counter to Faisal's point that playing Samir is, I mean, you know, yes, we could be saving a bunch of money by preventing these strokes, but I don't even know if we're preventing them, you know. So you have to, you know, it's a little bit of a house of cards. We have to have at least one, you know, there's never been a device that sold as many that never had a positive trial yet. It's never happened.
Well, Molly, what do you think? What does the benefit of it?
Yeah, so so first off, stroke is a very visceral sort of complication, right? Nobody wants to have a stroke. Everybody's afraid of it. However, this is a negative trial, whichever way you slice it. It is a negative trial. And if Samir sat on the other side, if he was not the PI and sat on the other side, he would be arguing the statistics till the day, you know, was dawned. So for us, you asked about the economics of someone with a disabling stroke. So we've done 2,000 plus TAVRs, you know, since the inception of our hospital, and I have been there for maybe 1,500 of those TAVRs, and I can count on one hand the number of disabling strokes that we have had. So I will tell you that it does not make economic sense if you look at it economically. My hospital is in the middle of the country, so we get the least amount of reimbursement, especially from those that are on the coasts. And so if we were to put a Sentinel in every patient, then we would lose $2,000 on every TAVR. I mean, that's with all of the the downstream, and we have cut this like economically every way, shape, and form you can, and it just does not make sense. And then and overall, again, what David has said, it is a negative study. It has always been a negative study, and all of them have been a negative trial. So it's hard to.
So Molly, do you guys not use it?
No, we do not use it. We actually, before the study came out, we were actually a big part of Protected TAVR. We enrolled, I think we're like in the top 5 or whatever. So we believed in the trial. And up until then, if someone didn't qualify for the trial or whatever, we had our own little criteria that we kind of made up. But then after the trial, like the bicuspid valves and all the subset that we thought was going to, we kind of stopped using it because there just wasn't a reason. I will tell you the only cases that we really routinely use Sentinel in is basilica cases, because they, and we just did like a unicorn. I don't know if you know what that is. That's deploying a TAVR valve in a hole that you make in the leaflet.
Oh,
so,
wow.
Yeah, it was really awesome. And we were probably going to do that instead of basilica. It was way easier than basilica. And we'll probably start doing that. But the only reason why we did is for the point that David made, that it does catch some debris. And when you do that, you really do tear the leaflets, and large chunks do tend to come off. So we used it in that instance. I believe in embolic protection. I just don't think we have the right device yet. So I will do every trial that comes up with a new device, because I believe that it's the right idea. I just don't think we have the right device.
So
Yeah, I
Molly,
think that's also important. I just want to make one comment because it relates, Faisal, to your question, or your original question. Sentinel and that cardio, I forget what the name of the device is now, but it was a net that sort of went in the aorta during cardiac surgery. It's not clear.
device.
What's that?
Embolics.
Yeah, Embolics, thank you. And so it's not clear to me that those are positioned well enough. Even the Sentinel device, all you see is a ring that's opened up. You might be missing it. You may also be injuring the blood vessel in some way. And so neither of these devices, do we have good confidence that they're ultimately doing what we intend them to do. And so I agree, we probably still haven't found the secret, way to do this, the best way to do this. And it might be the devices themselves that are limited.
So
Yeah.
I know we're running short in time, but I want to hear it last from David, because in the spirit of the title of this, will this change practice? It has, to some extent, in Molly's practice. What do you think generally, David?
I think there are still the most interesting thing from the study that we did in the TVT registry was the variability across the country. There were 600 sites doing TAVR at the time, and of those, 70% of the sites, this was done in 2018, 2019, never used the device once. 30% of the sites used it. With some variability in there. So it's clearly there are people. It's like politics. It's polarized in the world a lot. Some of it has to do with economics from it. I think I think that this. I don't know if it changed practice, but I think it reinforces practice, because I can tell you I practice at a place in the East Coast, St. Francis. We do 600 TAVRs a year, and we use it in every single one if the person has a wrist. We don't even know if it's good or not. But we still, we do it, and because the market is doing it, which is not the right answer. The good news is there is even a bigger trial that's happening, being done in the UK by great trialists in the UK, where they're going to randomize 7,000 patients. It's up and running. I think they've already hit 2,000 or 3,000 that they've randomized. Between those two, if we can't find a stroke reduction in those two trials, it's not working, definitively. If you ask me, my gut instinct is it works. I think it does work. It doesn't work perfectly. It doesn't work anywhere near as well as Samir, thought when they designed the trial. But time will tell. And I don't want to take up any more time.
David, are they powering it? Are they powering it the way that you recommended Samir to do?
They're powering it closer. They're powering it for a 33% reduction. If it were me, I would change the endpoint. At this point, I would change the endpoint and make the primary endpoint not all stroke. It doesn't prevent stroke. it changes if it does anything, it changes disabling strokes into non-disabling strokes. And so the endpoint should be disabling stroke if it were me.
Well, thank you so much to our panelists for such an engaging discussion.
Maybe like 10,000 patients or something.
Yeah, well, it's between the US trial and the UK trial, it'll be exactly 10,000.
Stay tuned. All right, Ray, go for it.
Oh yeah, this is just tremendous. And on that note, we'll keep it going. And I'm pleased to introduce and turn the reins over to Dr. Molly Szerlip, who will be presenting the Class 2D pivotal trial and how that might inform practice as well. You should have control now, Dr. Szerlip.
All right. So interestingly enough, I mean, this is not near as controversial as the other ones, and maybe we can make it controversial. I don't know. So I will go through the Class 2D pivotal trial. Now, so you said, okay, there we go. Okay. So mitral regurg is an extremely prevalent valvular disease, as we all know. Left untreated, you have increased hospitalizations, reduced quality of life, and increased mortality. So DMR, as we all know, is the Class 1 indication is surgical mitral valve repair. However, high-risk patients are usually not referred for any treatment, but if they are referred, then usually the surgeons say they're too high risk. And then overall, some patients who are high risk don't want to undergo the surgery. And we know that transcatheter edge-to-edge repair is approved for high-risk severe degenerative MR. So this led to the Pascal system. Pascal is a little bit like a mitral clip, except that it was the original independent grasping. Since then, mitral clip has independent grasping. But what's unique about it, it has this central spacer that will bridge the coaptation gap. And it's much more, the paddles are much more flexible. They have passive closure, and which is thought to be a little bit softer on the actual leaflets when they are put into this. Also, there's an elongation part to it, so it's much easier to navigate if you have dense chordae. So when you slip it down, if you get caught in the chordae, you can elongate it and it comes out much easier than sometimes mitral clip, which will wrap around the cords and you can actually tear the cords. There's only two sizes, which mirrors that of the 4 sizes of a mitral clip. So we have a Pascal Ace, which is not as wide, and the regular Pascal, which is a little bit broader and longer. All right, so the randomized trial came after, obviously, the EFS trial, and it was for symptomatic significant degenerative MR, and anybody who was deemed suitable for the edge-to-edge repair. It went under Echo Core Lab, and it was randomized to the actual Pascal system and then to the mitral clip system, and it was randomized in a 2-to-1 fashion. There was also a registry that we did these were people who we thought were suitable for Pascal, but not suitable for mitral clip due to the anatomy. So those people were then put into a Pascal registry. The primary endpoints for the randomized trial, this was a non-inferiority trial. So it was the composite of major adverse events at 30 days and the effectiveness of MR of less than or equal to 2+ at 6 months. All right, so the inclusion criteria is everything that you would think it would be, but just to point out, it was people with EFs greater or equal than 20% and an end diastolic dimension of less than 80. So this would cut out those Mitra FR patients. Exclusion criteria were severe right ventricular dysfunction, any rheumatic heart disease, any other severe valve disorders like significant TR, any significant coronary artery disease, or people who have less than 25 on their eGFR. There was also anatomical exclusions, and these were moderate to severe calcification in the grasping area. If there was a significant cleft greater or equal than 2 independent jets, also if the mitral valve orifice area was less than 4, or if the length was less than 8, or if it was kind of a Barlow's valve. So what they did was, so the Pascal, the actual trial is actually, total enrollment will be 300 patients, but they set endpoints to do a data snap. And so this is one of the data snaps. It was at 180 patients enrolled. So for the Pascal system, there was 117, and for the MitraClip system, there was 63. They were pretty even in deaths. At 30 days, they had almost all in the Pascal system were seen, and almost all in the MitraClip as well. And then at 6 months, it was about 94% visits were completed in the Pascal and the same in the MitraClip. So pretty equal. So what they found on the primary endpoints was that the Pascal system was not inferior to the MitraClip with respect to MACE at 30 days. And the major adverse events were cardiovascular mortality, stroke, MI, new need for renal replacement therapy, severe bleeding, and mitral valve reintervention, either percutaneous or surgical. And it met its effectiveness endpoint as well, which that it wasn't inferior to MitraClip with proportion of the patients with less than or equal to 2+ MR at 6 months. And so with this, it was how it got approved. All patients received the device. 1 Pascal was aborted due to inability to actually grab the posterior leaflet. In the Pascal arm, 67% of these were Pascal, 24% of it was the smaller ACE, and 8% had a combo of the two. In the MitraClip arm, 39% had the original NTs, and 60% once G4 came out had the NT, NTW, XT, or XTW. The mean number of devices was the same, so it was about 1.5, and the device time was the same between the two groups. So again, this is what the Pascal and Pascal ACE looks like. MACE was the same. MR reduction was the same between the two. So again, non-inferiority was met in both safety and efficacy. And then in all-cause mortality, cardiovascular mortality, freedom from heart failure, and all-cause freedom from heart failure, they were it was the same. Also, the NYHA class was non-significantly the same, as well as the 6-meter walk, KCCQ, and the quality, the other one, I forget what that one's called, the other quality of life questionnaire. So in summary, it was the first randomized controlled trial directly comparing the two tier systems. It met its primary safety and efficacy endpoints. There was a low composite MAE rate overall and a sustained MR reduction at 6 months. So it also showed some demonstrated favorable ventricular remodeling with improved forward stroke volume. So it was deemed a beneficial therapy, which was non-inferior to the MitraClip. That's it.
So you didn't emphasize the one, the one selling point, at least the
One operator,
the durability on the MR. I mean, that's been,
yes.
touted.
And so, yeah, you're right. So there is longer, or there is at least a trend towards more durability on the Pascal. So hopefully with the full data set, hopefully we'll still see that. I think one of the big things that people were afraid of with this, it is a bigger device, and there was a fear that there would be more mitral stenosis, which we have not seen. Also, there, the reason why there may be better durability, or we think that there's better durability, is really because of the nitinol frame and the soft, the passive capture of the leaflets. If you look at this, the leaflets move a lot easier with the Pascal device than they do with the MitraClip device. They're very rigid. And so the thought is over time, there may be, chordal tears with the MitraClip, but, it's all speculation.
I mean, so let me put this to Gorav, who repairs these things with, surgically a lot and does mitral clips. I don't know. I mean, I haven't done Pascal yet. Haven't used it. I mean, does the more durable MR reduction, do you believe it, Gorav? I mean, obviously it's, it's only, 60% of the trial data that we've seen so far, and it's a modest display. But there are other data sets, I've started to see them coming out of observational studies and things like that, which seem to show the same thing. So I wonder if it's real.
So I got two comments about that. One is, I am not a fan of anything that's causes tension on the heart. Strain on the heart is a bad thing. Anytime we're pulling tissue together, pulling, valves together, pulling aorta together, whatever it is, it's probably not a good thing. So having said that, if there is a signal because it's more rigid, perhaps that's the case. I want to just temper it a little bit, because this is 100 and something patients, 117 patients versus 63. Whereas David, you just presented a study where there's thousands, and now you're saying we need 10,000. I mean, on one hand, and I know they're totally different spaces, but we need so many patients to show that there is a benefit, yet we need so few to show that it's no different. I know that's the way we think about superiority versus non-inferiority, but it is very interesting, and I'm not quite sold on that it's necessarily better. I think there's some other features about Pascal that are nice, but like it's less likely to get entangled in cords, for example. Some of those things are a bit nicer. So I just saw the message, and Ray, I'll turn it back to you.
Dr. Kerkar, do you want to introduce the fourth and final talk?
Yeah, I think we'll move on to our last but definitely not least topic for today, with Dr. Bakaeen talking about ischemia and the 2021 revascularization guidelines. You should be able to advance the slides, Dr. Bakaeen.
And you're still on mute too.
Yeah, I got it. So again, thank you very much for the privilege. I'll just go right into it here. The reason we're discussing ischemia today is because of the guidelines, really, and because of ischemia, because ischemia is a good trial and the guidelines are controversial, and ischemia was featured heavily in the guidelines. And the critical point that many surgeons and some cardiologists saw as a sticky point is in patients with a stable ischemic heart disease with normal ejection fraction and significant 3 major coronary arteries with or without proximal LAD and anatomy suitable for CABG, CABG may be reasonable to improve survival. So survival is the endpoint. And it was given a class 2B, and the class of recommendation is based on risk to benefit ratio, and 2B is really questionable benefit. And level of evidence, BR, means randomized evidence, but not a definitive or not multiple randomized trials, but nevertheless it's based on randomized evidence. So whenever you see a recommendation like that, you say, hey, where is the data, where's the evidence? And there was 2 of them, 10 and 13, that were labeled as older studies that actually showed a survival advantage to CABG. The newer studies are 14 and 15, and reference number 14 is ischemia, and reference number 15 is a meta-analysis that in which ischemia was a significant part of. So let's look at ischemia. It's a large randomized trial. It was meant to be larger to look at all-cause mortality as an endpoint, but that would have required at least 15,000 patients. So they settled for a smaller sample of 5,000 eventually in 179 patients. And the primary outcome was a composite of CV death, MI, or hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. And the 2 arms were, as the name suggests, an initial invasive strategy which stipulated a coronary angiography plus or minus intervention, PCI or CABG for that matter, or initial conservative strategy with medical therapy alone and angiography if medical therapy fails. And if we quickly look at the primary composite outcome, up to 5 years with a median of 3.2 years, although there's some separation of the curves here, the p-value was insignificant and the all-cause mortality were overlapped. But when you look at death from cardiovascular cause or myocardial infarction, you see that the curves kind of diverge a little bit, maybe in favor of invasive strategy. And in fact, in a recent extended trial presentation at the AHA and just published in Circulation, the initial invasive strategy did show an advantage for cardiovascular mortality, but not all-cause mortality. We as surgeons really like, we're details oriented. So when we really look at the nuts and bolts of ischemia, we are disturbed by some finding, not because, again, it's not critical of ischemia, but it's critical of the interpretation of ischemia in the context of the recommendations for CABG. So if you look at the supplement table, number 9 of the primary publication in the New England Journal of Medicine, you will notice that CABG constituted less than a quarter of the revascularization procedures. And CABG and PCI are totally different. They are complementary. They have different indications and different outcomes. And in fact, the guidelines dedicated a full section, section 8, to talk about those differences and the advantages, pros and cons of CABG versus PCI. So the fact that they kind of lump them together in the synthesis of evidence, that didn't add up to us as surgeons and some of the cardiologists. And then if we look at the supplement table number 8, this relates to the atherosclerotic burden, if you'd like. And if you look at the native vessels with greater or equal 50% stenosis, and the proximal LAD is critical because virtually all of my patients have significant proximal LAD lesions. And the cutoff for significance for most of us is actually 70%. It's 50% for left main, but 70% plus for the LAD. But even if you lower the threshold to 50%, only 36.2% of patients actually had LAD, proximal LAD lesions of greater or equal 50%. And then there was a crossover. 21% of patients crossed over to the invasive strategy, even with a short follow-up of 3.2 years. So how can we relate that to the CABG, to the modern day CABG patient? And we can't get any more modern than that. We looked at the national sample, which is the STS database, which captures virtually the majority of CABG patients performed in North America. And in the modern day sample, about 93% of patients have free vessel disease, a plus or minus left main disease. And then if you look and put them side by side, the ischemia-like or the ischemia population versus the modern day CABG population, they're vastly different. So 69.5% have the three vessel disease or multi-vessel disease and ischemia versus the 92.9% in the STS database. But again, more importantly, the low incidence of proximal LAD lesions. Those, again, are not the kind of patients we operate on. If they don't have a proximal LAD lesion, I can't remember the last time I've operated on a patient like that. So clearly, there's a huge difference in the atherosclerotic burden between the ischemia population and the modern day CABG population. And this is very obvious in the clinical risk profile, the cardiovascular risk profile of the ischemia versus the STS population. The STS population are more likely to be diabetic and hypertensive and current smokers, and they are 2 to 4 times more likely to have cerebrovascular disease, peripheral vascular disease, or heart failure. We're not talking about a few percentage points. We're talking about orders of magnitude here of difference in the cardiovascular risk profile. So I know it's dinner time and I don't want to make you guys hungry, but I mean, frankly, there's really little overlap between modern day CABG population and the ischemia population. And this is important because when it comes to looking at the evidence, you got to look at the right population. I mean, when you say PICO, what does P stand for? The population. But I tell you what ischemia shows and what the new evidence shows. It's compatible with a reasonable recommendation that would say that in selected patients with stable coronary arteries and normal ejection fraction, an initial conservative management strategy with close follow-up, because remember the crossovers, is a reasonable strategy. And no surgeon, in fact, nobody should argue with such a recommendation. And I would give it a class 2A. You could argue you could make it a class 1, that's fine. And I would give it a level of evidence BR. Now, notice that they gave this designation, except that they gave it 2B for CABG, and they used B for randomized. Not a single patient in ischemia was actually randomized to CABG, or PCI for that matter. So how could they designate a level of evidence be randomized? This is the ACCHA. It's the gold standard when it comes to writing guidelines. So that kind of baffled us in the surgical community. So we felt that the correlation between the evidence and the CABG recommendations didn't make any sense. And we pointed out multiple other caveats that we don't have time to discuss now, but you could go to a recent editorial in JAMA Surgery that we put together, and we highlighted that this is an important case study where we shouldn't blindly accept summary evidence, but we should look at the source data and make informed decisions when it comes to choosing therapy for our patients. Thank you very much.
Thank you, Dr. Bakaeen. And, you know, we really have the heart team here on this panel. And clearly, these guideline revisions have created quite a rift between many members of the heart team. How do we work towards mending that?
Are you asking me?
Well, or anyone on
He's
this
asking
panel.
all of us. He's asking all of us.
I think in some circles I'm regarded as a pariah, but in fact, I'd like to think of myself as a course, as a voice for reason here. I think the ACCHA and SCI should come together with the surgeons and look at the evidence and do what's right. You know, the older studies that give CABG a class 1 are clearly older studies, and we should acknowledge that as surgeons. But when it comes to actually writing the recommendations, we have to be very precise about the available evidence. Otherwise, everything else we put down should be level of evidence C, expert opinion. And that wasn't the case in the guidelines. They did it, designated a level of evidence C, expert opinion. They said be randomized, when not a single patient was randomized to CABG in the newer studies.
I mean, I certainly would agree with, you know, really a lot of what you said, especially, I mean, ischemia just, you know, is a very specific group, you know, selected, you know, purely, you know, the only anatomic selection to get into ischemia was you had to have coronary disease and you couldn't have significant left main disease, which were excluded by the CT scan. So, and then there was a symptomatic exclusion, which is you couldn't be super, you know, super highly symptomatic. The reason being that they didn't want to have so many crossovers, because if you have really symptomatic patients, there's going to be a lot of pressure to cross them over. So they wanted to keep the patients apart from it. But, you know, and then the consequence of all of this is that you get this mix of, of different revascularization strategies. It's not a medical therapy versus PCI trial. It's not a medical therapy versus CABG trial. It's a, you know, it's a medical, you know, it's a medical therapy versus invasive angiography and do what you think is right trial. And that's, you know, it is muddy there. And I don't think, you know, I mean, I agree with you. They shouldn't, whatever your recommendations they make, they probably shouldn't be based very much on ischemia for this particular question. I mean, we have trials, you know, we have, I mean, I think the strongest data, I think you and I have talked about this in favor, frankly, of, you know, CABG for mortality reduction in 3-vessel disease comes not from the trials of, you know, CABG versus medical therapy, comes from the trials of CABG versus PCI. Where, you know, in 3-vessel disease, there was improved survival with CABG. And those patients have a lot more anatomically complex disease than these. So I think, you know, I personally, you know, think the message that, you know, came out from the original Syntax trial and, you know, a few that, you know, followed on that of that you know, that in patients who need revascularization, the strategy and the use of revascularization should depend on the complexity and extent of the coronary artery disease is still the right one. Exactly where you draw the line, 3-vessel NE, 3-vessel only proximal LAD, 2-vessel proximal LAD, that's gray. Diabetes modifies it enormously. I mean, if you have diabetes and you have 3-vessel disease, you should, run away from the interventional cardiologist and run to the cardiac surgeon. But, there's a lot of gray in there also. And I wish I knew how to get the people back to the table. That's the part I don't know, because I don't know why it broke down. I mean, it broke down, because there's surgeons who still are on that document. Some surgeons, walked away. The surgical societies decided to not endorse it. And so there was something happened in the middle of the process that I don't know.
Yeah, we'll do it over a beer.
Okay, you might need more than one.
Yeah, I just want to make one highlight, one comment you made, David. Yeah, this is a very select group of patients. As Faisal already said, it's not who we see. But I mean, how many of these patients that we often see as surgeons are truly stable in terms of their angina? A lot of them are not. And so this is a very unique population. And it's all of a sudden being extrapolated. And you can see how seems like the pendulum has swung pretty dramatically with a single study. So I think that's shocking and certainly worth even, sounds like surgeons and cardiologists making a comment and standing up against it.
Yeah, I don't know how many people follow the guideline. I mean, Faisal, are you seeing less 3-vessel disease in your referrals these days?
No, but I've seen examples, and I actually presented them, of patients who, anecdotally, of patients that were treated medically. One of them came with a huge infarct of the anterior wall with an LV thrombus. So there's a price to pay. And he was told by his referring physician that, oh, medical therapy is just as good. And the guy was having symptoms. He's one of those guys that crossed over in the ischemia study, but in fact, he had an event before he could cross over. So a word of caution. But at the Cleveland Clinic, we love the heart team. Those dense debates that go out on social media, etc., are kind of a little hyped, to keep people engaged. And it's we all work together. And I'm sure that the AC and the AHA, AATS, and SCS will come back together. And with Molly's pulling Sky, she'll bring Sky into sort it out.
Well, I will tell you, I was trying to sit quietly because I don't want to get myself in trouble, not with this, but the reverberations from what happened with this has really blown up a lot of things with actually ACC and AHA. So it may come back on a different platform with in other formats, and that's about all I can say about that.
Beer.
Yeah, exactly, a beer.
I do think in the United States, we again, especially through the structural heart disease sort of mechanism, the heart teams have gotten enormously, stronger than when I was in my early, career training. And it frankly has been one of the best. TAVR really, I think, is the shining star there of where, we work together, by design, we enjoy it, we learn from each other. That's when we, standing shoulder to shoulder with your surgical colleagues, working on the same patients, doing the same procedures, teaching each other. That's what we need to strive for in all of our treatments. Again, I think TAVR, to some extent, the mitral stuff, I think the tricuspid, all of that is the strength. The coronary surgery and PCI have the disadvantage of having started too early, before we really had this conceptualized, and we need to work hard to bring it back together.
Just to say, in our institution, our conference is on, we have a heart team conference that is basically all coronary and PCI, and we all discuss all the patients together. So this particular document has not changed the way that we practice. Actually, it was just a blip on our radar. And especially after all the controversy around it, we sort of just threw it aside and and still work with
Move
our
on.
heart surgeons the same way that we always have.
On that positive note, I'm just going to thank all 4 of our panelists for joining. Thank you for taking the time to create slides and teach us everything you did tonight, and for the lively discussion. And thanks to Ray for putting this all together and making some great introductions tonight. And then thank you to everyone who participated in the audience. We hope you learned as much as we did.
Well, thank you very much. It was a lot of fun.
Bye.
Have a
good
great
night.
night.